say let's take test tubes.
There you go. Oh, this is working. Good grief.
Yes, it's working.
I've got a small screen and a big screen. That's good.
We've just got the big screen.
Yeah, it seems to. I've actually created, or I was given some slide notes. I've never worked with notes before on a slide thing, so this could be interesting. Right, I'm ready. Let's give it another few minutes. I'll give you the graph just to absorb. There you go. Oh no, that doesn't work.
Oh, I've got to rejoin.
No, you haven't got to do anything.
Yeah. Do I have to use these buttons down here, do you think? Looks like it. Okay.
I've got a graph on the screen now.
Got a graph.
Yeah, that's fine. That's the current respiratory virus situation. As you can see, COVID is actually steadily growing, which is the pink line,
Yeah.
which is quite interesting. It's not where it was this time last year, but it's no doubt about it. It's been steadily increasing since about March, February time. Everything else, not so much.
In America, it's going to shoot up in the winter. It's going to shoot up. Those stupid people. The volume's gone now.
Give it another minute.
Graham?
Yes.
What that American woman was saying about the dietitian and also Mick. My mate who's got MCAS and Ehlers-Danlos, she's basically dying because she can't tolerate the elementals that the dietitian is giving her because of the sugar. And it's NHS doesn't recognise MCAS, and so she's on her own, and it's terrifying. She is so skinny. There is so much fermentation in the stomach, so she's and everything that she eats just goes straight through. That's a complication you don't want to have, a complication that the NHS won't even recognise.
Yeah. I don't know anything about it.
I know, so few people do. MCAS.
I've heard of Ehlers-Danlos, but I've never come across a case.
Ehlers-Danlos syndrome. Yeah, it's when the skin tissue doesn't renew so much. So her feet are sort of, it's painful to walk on her feet.
We've got a friend who's dangerously underweight. She's on the all the weight loss, all the weight gain supplements, and all her doctor turns around to her and says, "You're anorexic. Sort yourself out, and then get yourself fixed." And she's sort of saying, "I'm not anorexic. She can eat like a horse, but there's something there that's." And we have another girl.
Awful to say that to somebody.
Yeah, she spent 4 years with gastro problem. Eventually, she found a doctor at Northampton who specialised in this very rare condition and has agreed to treat her. She's advised her own GP at this part of the country but she can treat it. Unfortunately, she's on opioid patches for pain, and she can't have the new treatment until she's off the patches.
Oh no.
So she's working on it.
Okay. Shall we start?
Yeah.
Right. I think I've worked out how to do this. This is a graph. This is the regular graph, which now contains details of the main four different respiratory viruses that affect the UK over a period of a year. You can see we're right at the end. RSV, influenza, and rhinovirus. Rhinovirus is declining, and the other two are low levels. COVID has been gradually climbing. I think most of us probably know people who've had COVID in the last few months, actually. So something different going on there. We're not sure what, but one of the things to notice is that this is this time last year, and of course, at this point, rhinovirus quickly peaks. SARS has gone into a peak in the past. Everything goes in a couple of months. Influenza starts its climb, and so does RSV. And RSV, rhinovirus, are probably driven by kiddies going to school and spreading viruses around. We do not know what SARS is going to do, but we'll keep an eye on it, and I'll feed back to you this time next month. That's just for general information. Okay, so what I've done the last few months, which seems to be quite successful, I will talk about topics that I find interesting occasionally, but I'm asking for what questions, what do people want to hear? What questions do they want answered in places like Facebook and on in the Telegram group? And essentially, I've got 4 questions this month, and these are budgeting and given the biologics are not 100% effective or suitable, what is the situation around money? Do they have to choose between patients who gets the drug, or where do they have to choose patients who get the drug? What is the criteria, and so on? So I will go through that in a bit of detail. Although I can't go through these things in all the detail they really deserve, because it would take, each one of them would easily take an hour and would get very complicated indeed. And the chances are I wouldn't understand it either. So I'll try and do them as briefly but as informatively as possible. The second question was all about a little bit of now we're hearing so much about artificial intelligence. It's probably time to talk a little bit about what it actually is and how it influences medical work, indeed, and medical information. That's a question really posed by myself, because I wanted to set it all out in a sort of a structure everyone will understand of where we can use it now, where we can't use it now, what might happen in the future. Then we have long-term effectiveness of biologicals on lung disease, which is an interesting one. A lot of people now are taking biologicals. A lot of people are having good impacts, some not so much, but quite a lot do. And we were interested in how long that might last. Will it last forever, or will it last for a year, and so on? So I've got some answers on that. And finally, why do people who have a form of aspergillosis, who have been in remission for some time, why does it flare up again? And I've got some information on that. So 4 different talks, and I'll do my best to try and make it as clear as possible. Okay, so this is in the order I wrote these things, and I wrote them with some help from artificial intelligence, giving you a hint of how useful these things are. It's in the news a lot, but what does it mean for us as patients? Like I said, we're hearing a lot about it. We're hearing people say it's great. We're hearing other people say it's dangerous. What does it mean? And let's try and cover that in a little bit of detail. What is artificial intelligence in the case? Artificial intelligence is actually quite a broad subject, but the examples that are currently becoming very popular, such as ChatGPT, and if you could do a normal Google search now, nowadays you will see a panel appearing at the top of your search, which is attempting to answer your question in a bit more detail, and that's a form of artificial intelligence doing that. What I was a bit surprised at, if you go on NHS 111, the chatbot you talk to online is also using AI, which is a use I wasn't aware of. I know when you go on 111, you're taken through a whole string of questions, and there's an earlier version of software that will answer that sort of thing. I thought we were still there, but no, we're using artificial intelligence in the NHS 111 service, so that's great, and with all its caveats. And everyone will probably be aware of Alexa and Siri. Alexa being the Amazon version of something that's been around now well over 10 years. Siri probably longer on iPhones, where you have a conversation with your phone or with your piece of equipment in your home. But it's very, very simple, but it's artificial intelligence. It's a version that's quite simple. It's only made to do a limited number of things. I have one of those. I have an Alexa device at home, and it can basically does 3 things for you. It can play Radio 4 for me, which is nice, if I just ask it to. It'll turn my television on, which is nice, but it won't do anything else. It won't choose a channel and it won't turn off. It can do that one thing. So these things are quite limited. And the other thing it will do is set a timer if I'm cooking anything, which is very new. Limited use, but in its day, very useful, and we use ours a lot. I've thrown away my old radio because now I've got Alexa to play radio for whenever I want to. And it crosses over into your phone and so on. But what are these new forms of artificial intelligence that have broken through in the last couple of years? What are they actually doing? And what they're doing is actually a lot simpler than you might think. All they're doing is they're being fed a huge amount of information, some of it off the internet, although they're not generally directly connected to the internet because that would be too much information. And they could potentially harm the internet. We have had problems over the summer with aspergillosis.org website being asked to provide too many pages, something like a million pages a month it's been asked to come up with, and that's too much for the server it's on, and it tends to slow down and even stop working completely. And that is, in all likelihood, caused by bits of software working for an artificial intelligence company trying to collect information from the internet. So they have to be kept under, that kind of thing has to be kept under control. I've controlled it on our websites because our websites run through a caching system, which means I can say, stop sending pages, in this case to Vietnam, which is the main progenitor of this problem. As soon as I say stop giving pages to Vietnam, the problem goes away. America is a source of these problems as well. And what's the other place? Singapore. So there's quite a lot of issues of companies in Asia collecting lots and lots of information and doing it in such ways it's damaging how other people's websites are working. Once it's gathered all that data, and it's a massive, in the case of ChatGPT, this is a truly massive amount of data, and Google are doing something similar. It analyzes all of that information, and all it's doing is looking for strings of words and then working out how often a particular word comes after another word. So, for example, if you think of the capital of France is, then the usual word that comes after is Paris. So it learns that it's a high probability. If someone asks what the capital of France is, the answer is Paris. Now that sounds really basic, but essentially, amid all the fuss about are these things going to take over the world, that is all they're doing. The example here at the bottom is it's like you've got a smart parrot with a huge library of information. It doesn't understand what it's saying, but it can parrot anything out of that huge library, and it can match things up and give you a true sounding statement. It looks like it can understand it, but it can't understand it. I did think at this point I could actually show you some live search engine, some live AI, but I dare not at this moment because this is going too well and I might break it. Essentially, it's if you go to something like chatgpt.org, you'll be faced with a search box exactly like you are with Google. You write in your question there, and this Google would just present you with a list of matching websites or resources on the internet. That's been doing that for over 20 years. This actually tries to answer the question, and it does it in the context of the question, which makes it look really realistic. And it appears to have intelligence, but it generally doesn't. It's got some specific shortcomings, which are very important. Things that AI can already do to help patients in particular, and I would say a lot of the information I'm now uploading to our website, such as aspergillosis.org, I'm asking AI, in this case it's ChatGPT 5, version 5, questions about the NHS, questions about aspergillosis, questions about all kinds of things. And what it comes back with, its reply is always in very simple terms. So most lay people could understand what it's trying to say, which is incredibly useful. And it will also formulate and set out the answer in such a way that it's really easy to understand. I read through these for the stuff that goes on the website. It's like me having an assistant that's able to answer specific questions, and I'll put all the answers together and write something that makes sense. But the AI is doing a lot of the groundwork for that, which is really good. I can ask anything. For example, the question at the bottom there, which is explain what IgE levels are in simple terms. That's a question I've been asked on a number of occasions over the years, because of course we use IgE levels for diagnosis in ABPA. I asked the same question to AI. It will give me probably a better answer than the one I would give, because it's more complete. It'll pull in examples. It'll be in plain English. It'll be nicely written out in good grammar, probably better than my grammar, and it's really simple. So I'm going to carry on doing that because there's all sorts of particular questions I want to ask that come up in the different patient forums. And I want it to ask me, I have to know a little bit about it to know the right questions to ask to get a more full answer. But you could go to ChatGPT and start learning about simple things like IgE levels, and it will give you an answer. IgE levels will stimulate histone, and then you go, well, what's histone? So you would literally write in the search box, what is histone? And it wouldn't treat what is histone as a separate question. It would link that question to the answer it's just given you to the first question, and it carries on doing that. And you really get some really nice answers, and you can get a really nice level of understanding. And what we suggest, the level at which you could use that information is as ways to, if you're going to see a consultant and you have questions, well, prepare the questions using ChatGPT or something similar. So you already have reasonably good levels of understanding before you have your conversation with the consultant, and you should understand what they're saying a little bit better. It can't, it's not going to replace doctors, and I'll talk about that in a second, but it can certainly help you have conversations with your doctors. It can translate jargon. I know, I think Sam's often mentioned that she doesn't like acronyms. Oh, this will actually tell you what the acronyms are. You can actually say to it, give me my answer with no acronym, or explain the acronyms, and it'll do that for you completely automatically. And it's quite amazing when you see it working. Another terrific ability it has, I can ask it, tell me what the current research is on, I don't know, otomycosis, something like that. Something that maybe you might have 1,000 new research papers in a year. And I last looked 5 years ago, so I may have upwards of 5,000 papers to look at to get up to date on that specific subject. And what you used to have to do was ask someone who's already at a high level of understanding, can you write a summary for me? And they would go away, and they would probably take 2, 3, 4, 5 weeks to read through everything that's been written. Probably not 5,000 papers, but certainly find hundreds of papers to read through, and then come up with a summary for you. AI does a very good job of it in literally a minute, because it's really good at reading thousands and thousands of pages of information and summarizing what they all mean. What it isn't so good at is linking back out to where it got that information, but it's getting better at that, which is easy to understand when you realize all it's doing is looking for patterns. And if you don't give it a pattern to look for, it struggles, and it certainly does. Doctors are already benefiting, including myself, from AI in lots and lots of ways. We are here at MFT, at Wythenshawe, we are participating in a big program to automate. I think we're looking at breast cancer scans, and what they're doing is feeding a version of AI, not ChatGPT, one that's specifically made to do this job. And it's been fed millions and millions of scan information, there is X-rays and CT scans and all these type of things. And then you were testing to see if we give it another one, give it a patient scan, can it tell us, or can it give us a degree of risk that that patient might have cancer? And it does that kind of a job because it can refer, it can build an image information base from literally millions of images and remember them all at the same time, if you can call it remembering. Refer back to all that information and give you an idea of whether it thinks that patient has cancer. And it can do that better than humans in many cases, because a human can't retain 1 million pictures in their head. They are quite amazing. I've seen some of the outputs of these things looking at lungs for similar reasons, and it gives you information like, this looks a bit odd over here, this is a feature that you're not looking at, but it's slightly unusual, you might want to look at that in a minute. Over here we're seeing signs of what you're looking for, so you need to bring this patient back and look at them more closely. Other ones, it will say, no, there's no problem with this patient, no problem. So it's screening out the positive ones. And it does that incredibly well, better than, as I say, probably better than humans. But you then have to refer that set of scans, that set of patients to a human to actually progress from there. It's very good at analysing all millions and millions of scans, not so good at actually specifically looking for problems in specific patients at the moment. And it's very good at doing all that kind of things where there's lots of information. So if
David.
if we have thousands and thousands of lab results in a particular day or a particular week, it's very good at flagging up anyone who's got an abnormal test result, and they would do it intelligently. So it would look at combination of test results. Probably it's very good at actually coming up with letters to send back to GPs. Things are less likely to get missed. It's more likely to be structured in a predictable, consistent way. Specialist doctors no longer really have personal secretaries. There are rooms of secretaries, although they're getting fewer in number. I don't think we're doing this here yet, but it's certainly feasible that that won't happen before too long, because it's obviously a much cheaper and a more consistent way of doing things if it works out. And of course, research, which I've already described. It's such an amazing resource to use for looking. If somebody asks a question like you're asking here, I can literally put that question into ChatGPT and it'll come up with a very good attempt at an answer. Do you think to answer that prompt on the discussion, do you think you would be comfortable having your scans read by computer? Would you trust it? Or would you prefer to have the initial screening done by a human radiologist?
Both.
Both. I think we'll learn to trust this technology over time. I think at first everyone's going to want it all, which is what we're doing in the trial at the moment. The AI is doing its job alongside a radiologist doing their job, and they'll compare the two. And this sort of thing has been done in the past, and the AI for those limited tasks has actually been better than a human. And of course, the amount of time it saves a human person having to look at 1 out of 1,000 scans instead of all those scans is incredible, and likely to be a huge improvement on what happens at the moment, if it works out. But those safety tests are being done right now. So imagine this for patients. It's always there if you have questions, and I find myself using it since I've been using it for probably just over a year now. You can ask it anything, and it really gives very helpful replies. It replies in plain language. It's adaptable. I can give it PDFs. I can give it images. It's quite hard to find something it can't do in that context. It's not hard to find something it can't do when you know what it can't do. If I ask it a question for which there is no reply, really, it won't know that, and it will try to give you a reply anyway, which is what we're going to talk about in a minute. So it could build your confidence before going into clinic to understand more about what you're going to ask questions about and what the consultant's going to say. Interesting, yeah. Well, I've said how impressive the result, the reply you get back is, and a lot of the articles that I put up on aspergillosis.org are mostly ChatGPT structuring the answer with me changing quite small parts of it usually. How is it that it looks so human? Well, one of the reasons is our brains are essentially doing the same thing. So essentially kind of imitating the human brain, because the human brain and ChatGPT, I've told you ChatGPT, all it's doing is looking for patterns and probabilities of what follows what. And that's essentially how our brains work in this context, with pattern recognition, prediction of what comes next, and so on. The difference being it can do that work very, very well, and I should think future versions will do it even better. But we, as we know, have the ability to, as we've just been talking about, really, we feel doubt. We look at something and we refer it back to our lived experience, and we think, oh, I don't believe a word of that. Oh, I doubt that's right, and so on. A ChatGPT, an AI large language model, can't feel doubt. it will try and reply to any question, and it will make it appear that it knows the answer, even if it doesn't know the answer. It doesn't feel doubt, it can't project doubt. So you can't entirely trust what it's saying. You have to have another human being who knows what it's talking about to assess whether there is any doubt in what it said. And I do occasionally ask some of the more technical stuff. I ask it, it gives me a nice answer. And then again, I say, give me the links to the information where you got this. And it can't, essentially. It gives me a link, but it's a complete nonsense link because it can't predict what I'm asking it to do. So its ability to not feel doubt is a big reason why we can't entirely trust the reply that you get. So we would keep it at the advice level and the information level, and certainly not at the level where you will be diagnosing somebody's illness, for example. The analogy that AI came up with itself here is the human brain is like a traveler who finds his way using his memory where he's been before. He might use a map, and he knows how far something is to get where he's getting. ChatGPT is like GPS. It's a computer. There are lines on a map. It'll get you there, but I think what it's trying to say is if you're a human being, you might put it off for another day if you've had a look at the weather forecast, whereas GPS would carry on regardless because it doesn't know anything about the weather. And you'll end up very wet. So, and ChatGPT will end up very wet. It's that difference between what the two systems are coming up with answers. Yeah, so a little suggested little activity. When did you last guess what someone would say next? And I would imagine most of us, especially if we're married and we talk to our wives or our children, and you say something, you know what they're going to say back. Essentially, that's how AI is working. So if you believe what they say, you should believe what AI says. Differences. So humans link words to senses, to our emotions, to our lived experience. We have a much richer range of information inputted into these replies. All ChatGPT is doing is predicting text patterns. There's no true understanding. Humans can say, I don't know. AI will give you an answer, and it will give you an answer confidently, but it's sometimes completely wrong. Sometimes it's completely made up. And it's called, they've given it the name hallucinating, which I think is on another slide. And the AI hallucinates, and that's a potential danger, which is obviously why we don't use it in that context. Humans judge meaning, AI just matches words. So limitations, no real understanding. Hallucinations, it's made up but convincing answers. It's not personalized. Some of these limitations are clearly overcomable. It's not personalized, there's no case notes. Or we can, if we give it access to case notes, we can solve that problem. It cannot order or interpret new tests. Again, if it had the ability to write orders, it wouldn't be that hard to give it. So that's overcomable. It cannot physically examine. Or maybe you could have a scanning device and it could analyze photos and things to overcome that. It cannot sense tone or emotion. Well, you could be speaking into an AI and it could, I know there are already computer models that can sense tone or emotion in speech. Yeah. Those are the limitations. So it has no access to your case notes, obviously, because we certainly don't allow AI to access ChatGPT to access anything like that. In fact, they don't allow ChatGPT to access the internet directly for the reasons that they might run into problems with things like privacy and confidentiality and copyright, no doubt. Only doctors can request and interpret safely test results. It clearly can't do a physical exam, and it can't translate human cues like facial expressions, tone of voice, and so on. So AI cannot yet replace a human consultation. How far do you think before it will be able to do a lot of what we've just said? I don't think it will be. I think what we'll see is these AI models, and Google are developing something along these lines already, where you will be able to, it will be much better at acting safely. It will have a much better idea of context of what you're asking and how to give you safe information. And hopefully it will be much more awareness of whether or not it can actually give you a good question or it's making it up. Clearly, it's got no clinical judgment. It's not a doctor cannot weigh up the best choice. This is the other big, so its inability to doubt is a big no-no. We must have things that can doubt. But kind of related to that, AI has no way of probabilistic reasoning. So, for example, if I were to, if someone was, your doctor was trying to weigh up whether to give you a particular drug, knowing all the other drugs you're taking, he would be able to think, well, weighing all those things up, I think there's a 70% chance that it'll do you good and a 20% chance that it won't do you good. So I will go with the probability of 70% chance that it will do you good, and I'll give you that drug. AI cannot do anything like that. And that's a very important skill that doctors have, clearly. So that's another reason why these things are not going to replace doctors just yet. And it will be some time before they can actually do that, I would have thought, because that's really quite a difficult thing to program. Cannot balance risks versus benefits. It cannot exclude personal values and preferences. Only it could be made to do that fairly easily, but it can't at the moment. Doctors combine science and experience and patient perspective. AI cannot do any of those things. What work is currently in progress to improve its usefulness? Well, all those electronic records that are now on computer could be linked to AI. They would, if it was an NHS system such as Epic here or Epic in any hospital, I mean, they could add AI to those systems, and it would have access to all your health records. They would have to go through rigorous safety checks and confidentiality checks and all that in order to do that. So we're somewhere away from that happening yet. But you can imagine how useful that would be. Are much less likely to miss things. They're much more likely to analyze everything all at the same time in a few seconds. Every time you get a new patient in front of you, it could be an excellent tool to help a doctor, but not replace a doctor. Better fact checking, tools for imaging in labs we've talked about. We could get voice and emotion analysis tools are already being developed. We're all aware of the wearables that monitor your heartbeat, your percent oxygen in your blood, and so on. They're already on the market. They're already, I've got one on my wrist now that will tell me my pulse, which is currently 74. That is expanding rapidly, and it will be AI. The problem with these devices is they generate so much data. You would need something that can handle so much data for it to be useful, and AI can handle so much data. So put those two things together, you could see that being an incredibly useful tool in the future. All of these things are still experimental at the moment, of course. But the direction of travel of something like the NHS would certainly be to improve safety, improve diagnosis using this type of tool in the future. So safer NHS linked tools, plain explanations of your results. So you would get doctor oversight, but where doctors would lapse into acronyms and long words, I would be more likely to give you a plain English, easy to understand explanation, probably sending it out to your MyFT more consistently, less likely to miss things compared to a human doctor who might be late on a Friday night. They might be tired and they're liable to miss something. You might also get you all these interpretations in hours minutes rather than weeks, which sometimes happens currently. Oh. And we're all already using our smartphones for digital companions. Reminders, my diary is all on my phone, and so on. Okay. Yeah, I'm not going to get through half of these questions. Ooh. So, to conclude, take home message: artificial intelligence is a helper, not a doctor, which I think we would all agree with. It's useful for learning, for patients to learn and prepare questions. It's useful for me to generate patient level of information that's relatively complete. I have learned so much about the NHS systems and how it all works from AI telling me, well, this is how it works. There's these different groups, they work in these different ways. No one, I've worked for the NHS for 5 years and no one has showed me where that information is until AI did it for me, which is really quite a groundbreaking thing for so many reasons. You have to watch out for getting things wrong. You don't trust the answer. If you are not sure of the answer, you've asked a question, you might think there isn't an answer. Be careful it's not making up the answer that it's given you, or it might be missing the context of the question that you've asked. It can't do a lot of things because it can't access the physical world. It's not a person, it's not a doctor, it's not a human. And your human clinician remains essential for safe care. But we might ask for how much longer, probably sometime longer. We will see these as being developed as tools for the human clinicians rather than any thought of replacing human clinicians. And that is the end of that talk. Has anyone here used AI yet? No?
On the AI looking at scans, my local consultant showed me I think it's my last CT. She said, "Can we have a look at this?" The AI, whatever, has highlighted the areas that are incorrect, that are sort of not normal. And she just said it's early days, but it is what we are already using it, giving it trials. Yeah.
Yes. So those trials they're happening here as well. I think the aim is to see if we can start using these things probably in a year or two.
Right.
I would. That's my estimate. But would that worry anyone?
It's nice to have somebody in person explain it to you. Like, oh yes, you've got all these red or purple areas, but because it's frightening when you see. I find it frightening.
You need the human to interpret what it's saying is abnormal. But then, if you take those questions, take those answers, and put them into AI, it'll explain what those features are. More.
That's true, but also you've got to take into account the fact that the person you're talking to is not always able to understand, be emotionally capable of taking in what you're telling them.
Yes.
You need a human with empathy, and to be honest, we all know not all the medical profession has empathy.
Absolutely. And that's a big shortcoming at the moment.
Quite. So you really need a very special human being with a medical background to do what AI will never do. However, a lot of people will prefer the unemotional AI, or rather they will be grateful for the unemotional AI telling them in black and white what the hell's going on.
I think you're right, and I think we already see. I send messages out to all of our patients after every clinic, but I send them out to their smartphones, and 99% of people have given us a smartphone number. So we can only assume that 99% have access to this phone. Might be their child's phone or something. But if a lot of people are elderly, are they likely to have smartphones? Are they likely to be able to use them?
Exactly.
I mean, my mum can, but I know plenty of elderly people who, in fact, my mum's sister, who wouldn't have a clue and needs to be led through all her medical investigations and so on. So we're not saying that the human person is going to disappear. What we're saying is we're trying to make their job a bit easier and maybe help them work faster. Certainly has made my work a lot faster. But of course, I'm not diagnosing patients.
Yep.
So, interesting stuff. Rapid development, all sorts of other things. Medicine and health is an obvious place to develop these things. Wait and see. Maybe I should report back in a year and see where we've got to.
How will we know it's you?
Exactly. Well, I can appear on camera, but then again, that might be a virtualized video.
That might be a virtualized. It might be a hologram.
You've known me this long. Maybe it's killed me and buried me in the grounds, something like that. It is. It's a very. And I remember when these things exploded maybe a year ago. The number of people coming on Radio 4 as I'm driving to work and back, worrying about AI having access to things like a nuclear red button. And this is much smaller, but your health is your nuclear red button.
Yeah.
So it's a lot of work to be done on trust and the clarity and laying out clearly what the limitations of these things are. And ironically, until I asked AI itself what its limitations were to do this talk, I wasn't 100% sure what specifically the limitations were with respect to has no sense of doubt, has no sense of probabilistic prediction. And that makes it completely clear to me, but that won't mean anything to my auntie Enid, who doesn't understand any of those things. So I mean, you could be quite well, I don't know what the word is, gruesome, and say the older generation are gradually going to disappear, and gradually more and more of us are going to be able to use this stuff. So let's say 20, 30 years time, and hopefully I'll still be around. This stuff has become embedded into everything we do, but it's not going to be taking over medicine from people for some time to come yet, if ever. There are lots of things it might be able to take over, but maybe not medicine itself.
Yeah.
Useful for learning, limited for judgment. I do recommend you go and have a look if you're that type of person, because if you don't understand something, you can ask it to explain what something was. It'll do it in more simple terms, and it'll keep doing that because it's just a machine. But can you fully trust the answer? Maybe not yet. You can fully trust my articles, obviously. Right, well, that took such a huge amount of time.
That was amazing.
I'm now stuck. We can whiz through this because this is quite short, and then I'll leave the other two answers to next month because we're running late. So, the budgeting problem. Essentially, the question was, is there a point where we have to choose between, doctors might have to choose between patients as to who gets the drug? Well, I've looked this up with my usual support from my assistant. And these are the answers I got. Here's how it works in the UK under NICE. There are rules. Biologics themselves are powerful, targeted treatments. They're not 100% effective for all patients, and they're very expensive, routinely thousands of pounds per patient for each year. How does the NHS decide? It looks at cost effectiveness, which is value for money. It reviews trials that have been done. So in order for something to be, this is why we have to have clinical trials before we can use medications, because you'll only get NIC approval once you've done enough clinical trials to prove that it's effective and it's cost effective. There's no point in introducing a new medicine that is as good as an existing medicine but costs twice the price, because that's not cost effective, and the NHS will not buy it.
Can I ask a question? Do you think there's a point at which cost effective will ever come to include the question, how much does this person earn, and how much does this person pay in tax? Is this person useful to society? Is this person contributing to society?
I've never seen a measure proposed or in use that does that.
Yeah.
It's simply this measure, the QALY, is a method for estimating the use of a life, I suppose. There's probably a better way of explaining that, but it's a life. It's not a life that earns £250, £1,000 a year. It's a life, and each of those, and what it costs the NHS to maintain that individual's quality of life. That's how the NHS is set up, and that's how the NHS continues. And there is a threshold how much the NHS will pay per QALY year, which is 20 to 30,000. The biologics have now crept under that limit, so that's why we're starting to be able to use them. If they're over that limit, and also I could actually do a whole talk on QALYs, which is probably a good idea, because it's quite interesting how they're working out the value of a life, essentially. And this type of work has been used across Europe for years now. And you have to have some method to assess what cost effectiveness means. And if the quality of a person's life is not that measure, then I wouldn't know what you would want to replace it with.
Russia and China have got a different version.
Yeah, I think, well, you would imagine a communist society would make these drugs available universally, but I bet they don't. That's a really interesting point, isn't it? Maybe I should look at that shortly. Brexit is only restricted if it's too expensive, essentially, and it's only too expensive if it's not effective enough, as well as it costs too much to bring into the UK. And bear in mind that the NHS has a massive purchasing power and usually gets these prices that you'll see on online pharmacies put by huge amounts because they really want to provide these new drugs to the NHS, and the NHS charges them huge discounts. Typical criteria for biologics, which we all know about. So I'll skip past that because we've only got 5 minutes left. If you meet the criteria, NHS will fund. If you don't, it won't. And doctors are required to follow this guidance. So more uptake, so the more popular a new drug is, does not mean that that drug will be restricted to other people, which I thought was pretty clear. Once it's approved, it will get paid for no matter how many people need it, but they can set the criteria to reduce demand up and down, I guess, is another way of limiting access. Once criteria is set, it takes some time before criteria can be adjusted.
My son has just fallen foul of that. His GP has told him, you're overweight, you must lose weight. So he says, okay, can I have one of these fancy injections then?
Yeah.
No, you don't qualify.
Yeah, you've got to be...
you're not that overweight.
You got to be BMI over 35, haven't you? Something like that?
Yeah, he's not quite, he's not in that level yet. So he says he's got his doctor telling him he must lose weight. There's a medication he can take which will help him, but the NHS won't fund it.
It's a tricky one, isn't it? Because you can sort of see why the NHS is saying, look, you lose some weight, we don't need to give you this drug, so the ball's in your court.
Yeah.
But there must be a point at which they say you can't lose weight, so we'll give you this drug. And the NHS spends billions on drugs that are related to lifestyle. But it's very difficult to start selling that. But I think that's what I see increasingly happening. More biologics coming. There are, so with the increased availability of all the different biologics, that will also cut prices. If long-term savings, fewer hospitals. So if this drug leads to things like fewer hospital stays, the savings to the NHS, I'm always a little bit suspicious of that, because at what point have we ever measured the impact of a new drug on doctors having to work less hard? I don't think there is any system by which we count the number of people going through a clinic, like our clinic, and then we introduce a medication and it stops people going through clinic. Then we can say, oh, we've saved on 100 patients a month or something. The mechanism is simply not there at the moment, but maybe you can see that happening. I don't know. Okay. I set some rules up front, not case by case rationing. One rule is set up, the rule is the same for everybody. And this is the sentence that confused me. Access may change as prices fall and evidence grows. Always discussed, that wasn't the question. That wasn't the. It seemed to indicate, that even though it denied the more you use, the less access there'll be, there is at the end of the day a cost issue. So you can see it being adjusted in different ways, like adjusting criteria. But I don't think it's not going to happen quickly. Do you think that, I haven't really explained that very well, but do you think, are you happy with the fairness of this system for allocating new drugs?
It's a tough one, really. I don't, because we don't yet know, and we patients haven't got access to all the statistics as to their effectiveness and why they work on some people and not on others. It's very difficult to, and maybe AI will tell us that in future, that the drugs are more likely to work on this set of people rather than that set of people. So don't even bother trying with that set of people, which itself is dangerous, because now you've got AI telling you, don't bother with that set of people.
Well, that would fall under NIC's responsibilities, so they'd have to be very careful about doing something like that.
But I certainly,
can see it happening.
Yeah.
Well, I think we've run out of time. We've come to the end. I've got 3 more questions. No, 2 more I could have answered.
Next time.
One of which was a biologic one on long-term effect of biologics.
That would be really interesting.
I could whiz past the important slides.
Yes.
Have they been around that long enough we can make the judgment yet?
In some cases, yes, but some cases, no. So there's that. Long-term effectiveness. Okay, blah, 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 blah. Oops, no, back one. So, omalizumab, good long-term safety record. Going back one. Sustained reduction in exacerbations, OCSs, oral corticosteroids, over 5 to 10 years. So we've got good evidence that the omalizumab works for 5 to 10 years. Good safety data. That was the first one, and that's been around a long time. So we know quite a lot about that. Mepolizumab, we've also got good data, safety data. for what are called extension studies, 4 to 10 years, we know that they're generally useful and safe. Possibly longer, but obviously we haven't been using them for longer. So in time, we might get longer trials. Bimranizumab, we've got information about them with regard to asthma, efficacy and safety up to 5 years already. Dupilumab, blah, 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 blah. Less information, benefits sustained around 3 or more years. So obviously that will go up in time. Sezapalumab is the new one. And all we have is 2-year data. And over that 2 years, there was sustained control and reduced exacerbation. So they're all pretty good long term. And if you stop, you tend to not go back to the start, but if you stop taking them, they stop working, not surprisingly. So you need to keep taking them to keep the benefit. And that holds for other biologics in other illnesses as well. So stopping them, i.e. de-escalation, should only be considered with careful planning.
Graham, I've got a question, it's Gwyneth.
Yeah.
You know, my immune system doesn't work and I take gamma interferon. I think the worry is that the biologic would knock the little bit of my immune system that works. Is that a thing?
They are concerned about, let's just try and bring us back to the camera 1 sec.